In this part of lecture, I am going to talk about experimental study. In experimental study, exposure to determinant assigned by an investigator. Investigator actively attempts to change a disease determinant or exposure or behavior or progress of a disease through treatment. One example of experimental study is randomized controlled trial. In randomized controlled trial, individuals are allocated at random to receive one of several interventions. The important features in randomized controlled trial are randomization, control, usually placebo, and blinding. A controlled trial is a study in which participants who are free of the disease or outcome are assigned to a study group. In a randomized controlled trial, participants are assigned to treatment condition at random. In other words, they have an equal probability of being assigned to any group, either intervention or control. Procedures are controlled to ensure that all participants in all study groups are treated the same except for the factor that is unique to their group. The unique factor is the type of intervention they receive. The primary goal of conducting an RCT is to test whether an intervention works by comparing it to a control condition, usually either no intervention or an alternative intervention. Outcome will be measured at the end of study period or at the end of follow-up time. Why we need randomization? In RCT, patients are assigned to treatment and control group by random allocation. This is to ensure all patients have an equal chance or probability of receiving either the new therapy or standard therapy or placebo. So this is to minimize selection bias by the investigator, and also it will minimize the confounding bias. The control group in RCT is the comparison group. This is either the standard or current treatment or can be placebo. In clinical trial, experimental treatment are often compared with placebo to assess the treatment's effectiveness. Placebo, just an inactive pill, liquid or powder that has no treatment value. Another important aspect of RCT is blinding or masking. This is a procedure in which one or more parties to the trial are kept unaware of the treatment assignment. There are many types of blindings: unblinded or open label, single blind, double blind or triple blind. In unblinded trial or open label, the situation where we can apply unblinded trial, this is where for the convenient purposes or when operationally is not possible. Such trial occur when it is not possible to mask the intervention. Example includes trial of surgical procedures. The advantage of unblinded trial, this is easier to conduct and less expensive. We can monitor prescription of other medication. We can improve investigator decision to continue a subject in the trial or to withdraw the patient. However, the disadvantage, there is a possibility of bias still exists from the trial subject, physician or investigator, and the statistician. In single-blinded trial, only the trial subject are blinded. The investigator and statistician are aware of the intervention received. The advantage of this is simple to carry out. Caregivers have all information needed for treatment decision and avoid biased response from subject. However, there are still possibility of bias exist from the physician in evaluating response from the intervention group or in prescribing concomitant and compensatory prescription. In double-blinded trial, neither the subject nor the investigator are aware of the intervention allocation. Ideally, clinical trial should be double-blind to avoid problems of bias during data collection and assessment. The advantage of this, the possibility of bias arising from the subject or investigator is reduced. However, data management of the trial data and safety data must be managed by an independent body other than the investigator. In cases of treating an emergency, it may be time-consuming to break the blind. In triple-blinded trial, participant, person who administrating drug and researcher or statistician are unaware of the intervention received. The committee of the trial is simply given data for group associated with the trial. Intervention group will be revealed at the end of study by the committee. Analysis in RCT. Randomization is a powerful way to solve the problem of differences in the natural course. So this principle should not be undone in the analysis. One of the important concepts in the analysis of RCT is intention to treat analysis. Once a member of cohort, always a member of cohort. Contrary to analysis of only those patients who really receive the treatment or per treatment or per protocol analysis. Intention to treat is a method that includes non-compliant patients in the groups to which they were originally randomized into. There are two reasons why this approach is used: to preserve the effect of randomization and to provide an assessment of the practical impact of a treatment. From a RCT, there are many outcomes can be measured. These are some of the important effect size that can be measured. We can measure relative risk reduction, absolute risk reduction, number needed to treat, or number needed to screen or harm. Example of the calculation. Imagine that 20% of placebo group get disease compared to 15% of drug group. The risk difference or absolute risk reduction is 0.2 minus 0.15 or equal to 0.05. Relative risk is 0.15 over 0.2 or 0.75. Relative risk reduction is 1 minus RR, or in this case 1 minus 0.75 or 0.25. Number needed to treat to prevent one event is 1 over ARR, or in this case 1 over 0.05 or equal to 20. There is also possibility bias in RCT. One is selection bias. This can happen due to lack of concealment of allocation or due to attrition and differential losses. Information bias also can happen where participant respond bias due to lack of blinding or outcome ascertainment bias due to, again, lack of blinding. There is also possibility of bias due to competing interests, loss to follow-up, or during the analysis of result. Either the result were analysed according to intention to treat or per protocol analysis. The disadvantage of RCTs includes limit to generalization, where the result of this study only apply to the selection of the study population. Second is budget. RCT is usually expensive and takes long times to complete. And finally, the ethical dilemmas involved in RCTs.